Good morning. This is a modification of a previous talk I gave on polytrauma CNS infection. You may recognize a few of the slides, but for my goals today, one is just again an overview of brain trauma neurosurgical intervention in the polytrauma patients and the unique problems that arise from that, including the use of craniectomies to decompress the brain, but the complications of those, the use of cranioplasties to fix the craniectomy hole, and the complications of that. Some discussion of EP shunts again, and use of intraventricular antibiotics, but also a little discussion new that on biomarkers for traumatic brain injury, which is actually an initiative that's been started here at the James A. Haley VA in support of polytrauma research. So just kind of a brief history of CNS trauma. It's obvious that since beginning of time there's always been a war, and there's always been brain trauma. This really didn't become a topic of medical review until about World War I, when there were several articles published discussing management of open head wounds. At that point, 60% of wounds that penetrated through the dura were fatal, and usually due to infection. Obviously, they didn't have great antibiotics at that time. Surgical debridement did seem to reduce deaths by half, so even without antibiotics, the principle was that if you could take out a devitalized bone and particulate matter from the outside, that you could markedly improve a lot of these severely damaged patients. And then in the 60s, excuse me, with the wars in both Croatia and Vietnam, the death rate was reduced further to about 10 to 17%. Again, this was a combination of use of antibiotics, but also improving neurosurgical techniques. By the time of Desert Storm, 4.5% death rate was observed, and again, this is due to further modifications in neurosurgery technique, some of which we'll discuss. Okay, the presentation of infection in these patients has usually been either early or late abscesses, but more typically you can see osteomyelitis and meningitis. So there's a variety of infectious complications of head wounds that involve infectious disease consultation. Most of these infections are usually from external sources, almost always skin bacteria, streptococcus, staphylococcus, or environmental agents such as Acinetobacter, which is the more frequently seen these days, and occasionally some anaerobes like Clostridium. Including the use of antibiotics in infected head wounds is very much affects the final flora. So just a quick review of traumatic brain injury. This obviously can be split up into penetrating injury and non-penetrating injuries, including blunt force, but also blast injuries, where you have a cerebral trauma despite the fact that you have an intact skull. And the way this works was elucidated during some of the Croatian conflicts, was that blast injuries, which have become sort of a hallmark lesion of the current overseas wars, has been associated with cerebral damage despite absence of any penetration. And the current hypothesis, partly confirmed in animal models, is that extreme atmospheric overpressure on the torso couples a pressure wave to the arterial and venous blood vessels into the brain, and this can result in a transient and very dramatic increase and then decrease in blood pressure in the brain. This results in shear damage to the different tissues within the cerebral cortex. The other important fact about this is that there may be a much larger population of patients with significant brain trauma that are not recognized because they had no penetrating injury or did not have blunt force injury to their head. And part of the backlog at the rehabilitation center here in part stems from the fact that years after the fact, patients are beginning to show some evidence of traumatic brain injury, even though they didn't have a direct force applied to head either in a penetrating or non-penetrating fashion. And the reason that this traumatic brain injury tends to occur after a leg of time is it's probably having to do with, because of the shear, you damage the axons of the long neurons, and that then damages the myelin sheath and some of the supporting cells that keep these long nerve fibers active and vital. And once that happens, then the axon begins to break down, and when that happens, you actually kill the neuron itself. And so over a period of weeks to maybe even longer, there's this slow dropout in axonal axons and nerve cells. This is often identified, this diffuse axonal injury they call it, can be identified by MRI because there are little speckles of hemosiderin where there had been some small capillary bleeds where the axons had been at one time. Usually there's also loss in the cerebral mass. So this is clearly a recognized sequela of blast injury. But it isn't all just axonal shear and loss of neurons. You have more traditional forms of brain trauma, particularly either penetrating or blunt force. And just to point out that there are multiple forms of herniation should you have edema or bleed. Just pointing out the various types, and I don't have a oh, that does work. Okay. And so, you can have a variety of herniations. You can be transfalcine. It can be transuncal when you begin to push down into the posterior chamber. Central when actually the whole center portion of the brain tries to squeeze on down. External, which in our case we can actually use therapeutically, as you'll see in a little bit. And finally tonsillar, where actually a chunk of the cerebellum is trying to squeeze on down into the spinal canal. Okay, so here's the problem. A patient with a closed head injury who, you can see some edema around here, but essentially the ventricles are all squeezed down to tiny little slits here, and this person clearly has massive edema, and it's all in the closed box that is just going to squeeze out the ventricles, and this patient's at very high risk of a herniation. And the interventions that have been devised over the last few years have taken advantage of the fact that if you open up, and here you see they've taken off some of the skull and some of the skull here, you can actually begin to allow the brain to swell out past its usual boundaries here, and that effectively decompresses this closed box. This is an even more extreme example of where bone has been removed in a craniotomy. And you just let the brain material kind of come out here. It's all covered by dura at this point, and also you still have the aponeurosis of Galen. So he has some very tough tissues around this. This turns out to be, clinically, there's several advantages to this one. You do decompress the brain, and although it's never been studied in a controlled style, because I don't think anyone's ever going to do a controlled study here. The general thought is, in fact, that this is something that is life-saving, because certainly lesions that were fatal before do seem to be surviving now that they can do these craniectomies. I had one other little thought there, but I'll come back to it. Okay, and the way it usually works in both civilian trauma centers and also in the military is, the trick is to identify increased intracranial pressure early on. Usually the patient mental status declines markedly, and with a CT scanner you can usually identify the need for managing the CNS pressure. Early intubation and overventilation, it can be initiated, but ultimately what you need is a well-staffed neurosurgical group that can provide intracranial pressure monitoring. And based on what happens to their intracranial pressure, if it's prolonged for a certain length of time, there are these criteria that allow them to identify impending herniation, and they're taken straight to craniectomy. And once you open up the skull, that same monitor in place will show you a fairly immediate reduction in intracranial pressure, so it clearly works. And just to point out, now once you've taken out the skull, you can save pieces of it. Sometimes you can implant it into the peritoneum. That's certainly done. Unfortunately, something like 20% of those do infect at some point. I think it's just handling it and putting it into another incision is just too much, and occasionally it becomes infected. You have to remove the skull flap then and toss it out. again, just pointing out that once you take out the bone, you would think that the brain would be very vulnerable to trauma, and that's true. But again, you do also have all of these pericranial and aponeurotic tough fibrous membranes, and also the dura that protects the brain. It's of interest because often this results in a very sunken appearance to the scalp. And in a way, you can use that almost like you might use a fontanelle in a baby with meningitis. On a good day, it's sunken, and the patient is lucid. If they begin to develop hydrocephalus, for other problems begin to develop, you can actually, in fact, the family will be the first one to tell you that, yes, their skull flaps are beginning to fill up. And there were several families that could pretty much precisely identify when the patient was going to start having some decreased sensorium because the flap had really filled to a certain extent. So it's fairly reproducible, and it makes for yet another form of vital sign at the bedside that we never really thought to use before. Okay, but there are downsides to craniectomy. Some people do well with it, and they walk around with a sunken flap for long periods of time. The problems here are, one, cosmetic. It's not, you tend to draw attention, I think, in a crowd from that. The other thing is you do have unprotected cerebrum susceptible to trauma. You don't have bone over it anymore, so if you were to fall onto that unprotected skin flap, there's a real chance of increased brain trauma. And the worst thing about the only thing that's worse than having brain trauma once is having brain trauma twice. There is this observation that a series of brain traumatic events is always much worse than one event. And this is true for IED explosions as well. And for a while, the military was trying to limit the number of explosions that soldiers were exposed to try and prevent that cumulative damage from occurring. Okay, well, cranioplasties. Okay, so the whole point here then is that rather than just leaving that defect there, it is desirable to actually insert artificial bone or the original bone. One other point I just want to make here is that there is a thing called the syndrome of the sunken flap, or the syndrome of Trephined, which is that the atmospheric pressure pushes down that skin flap, and there are observations that those patients don't seem to function as well in terms of cortical function, and as soon as they get a cranioplasty, many of them actually have a fairly dramatic return of function. I've seen that 3 or 4 times. In other patients, it doesn't seem to happen. Okay, so the cranioplasty is nothing new. This was actually employed quite extensively in World War I by Alexander Primrose, CM. I'm not even sure what that is. And they used mostly bone, harvested from different parts, cartilage and fascia, and they could close these things up, and they actually did pretty well, although at that point they recognized that infection was a huge problem with these cranioplasties, and to some extent it still is. So the syndrome is defined in a little more detail, sometimes called the sinking skin flap syndrome, in part because atmospheric pressure is pushing it on in. It does seem to compress brain, and in terms of using SPECT scans and sometimes functional MRI, you can actually see decreased activation of the brain tissue adjacent to the flap, and this goes away once you would restore a cranioplasty. The thought being there's some long-term underperfusion of cortical areas. And again, I've seen patients who were very impaired, could barely talk, and within a few weeks of having your cranioplasty were markedly better, despite having been at a low level for some number of months. Okay, just showing you, here's a patient with a craniectomy. This is the sunken flap here, and you basically, you can push down in that, and you're right on top of the cortex, though underneath a couple layers of fascia. And there are a couple ways. You can either use the original skull flap, though increasingly that seems not to be working. But you can also design these methacrylate or sometimes titanium cranioplasty based on computer modeling. And they can even develop these casts where they can practice implanting the cranioplasty. And when it's done, you've got a suture line here, but the shape of the skull is restored. So from a cosmetic and both a functional point of view, there's some potential for improvement. Okay, well, the only problem with cranioplasty, of course, is it's artificial material, and like any artificial material we implant, there is a risk for infection. And this is not a whole lot different, I think, from implantable joints, in that you know, the epidemiology is not very well described, although there is a big database that's slowly working towards IRB approval for analysis one of these days, that Steve Scott has. But just anecdotally, the sort of infections we've seen are probably not surprising. Anything you would expect to see with other implanted objects is true here. Pseudomonas, Staph aureus, MRSA, coagulase negative staph is fairly common. Canada we've seen, and actually a fair amount of occasional diphtheroids and Propionibacter acne. You see a few of those as well. The infected cranioplasty can actually be a bit of a surprise. We've seen two where they had no fever, and it's just they had some headache. And eventually we begin to notice there was a lot of swelling over the cranioplasty. Now, swelling over the cranioplasty occurs anyway because the CSF will often leak around the cranioplasty, and you essentially have what they call a fifth ventricle overlying the cranioplasty, but underneath the aponeursis of Galen. And you can kind of squeeze on it, and you can move the CSF fluid back and forth into the brain and out. But sometimes it becomes very tense, and the patient's clearly not doing well, and that's when you start thinking of infection. A CT will show subgaleal fluid in air, and sometimes epidural fluid in air. So it's hard to miss once you get to the point of the CT. Treatment is just like you would treat an infected knee joint. It's a little bit easier actually because you take the prosthetic material out and found a great functional loss. You treat with antibiotics and then do a replacement procedure later. And we've seen a few patients go through 2 or 3 cranioplasties before they had one that they could keep. In many cases, you know, the cultures sometimes are negative. What will often happen is people will treat it empirically, often before they send them here. And if we don't have any cultures to work from, empirically, we'll just go for meropenem and vancomycin. And meropenem in part because Acinetobacter is such an important concern in these patients. Okay, so wherever you have a cranioplasty and brain trauma, you sometimes also have a VP shunt. And I'm just going to go through this fairly quickly. We went through this once before. But so here you have your VP shunt in the ventricles. Just to recap very briefly, your CSF is produced by the choroid plexus, and there's a choroid plexus in every single ventricle. So you basically got 5 choroid plexi, as it were. They produce the fluid, comes out, and then circulates up and down the spinal cord and then over the cerebrum. The fluid then is taken up by the arachnoid granulations, which are scattered throughout basically the arachnoid matter. There's also uptake within the spinal nerve roots as well. What drives that is it's really almost a pressure phenomenon, that there's a slightly higher pressure here than you do in the venous bloodstream. That's on the other side of the arachnoid granulations. And so it's a one-way flow. If you have meningitis or if you have a intracerebral bleed, those proteinaceous particles and gunk will go out here and they block up the arachnoid villi, which is one of the causes of hydrocephalus in this situation. And so obviously the only thing you have left to do, rather than letting the cerebrum flatten out against the inside of the skull, is to basically divert it down into the peritoneum. And I think you're all pretty familiar with that. Just an example of where the placement is. And as most of you probably already know, is that the VP shunts these days are a little more elaborate than they were 20 years ago, in that now you have these programmable shunts. You can use a magnet or other devices, and you can essentially sort of customize the flow rate so that you can keep the ventricles at just the right size. It is possible to have too high a flow rate, and the ventricles will begin to you can actually develop a little traction on the inside of the ventricles, and the patients don't seem to do as well with that. Okay, so the VP shunt complications, again, it's foreign material, so again, it's infection. Rather than dwelling on the usual cast of suspects who cause infection here. Just to point out that recognizing a VP shunt infection, they don't always present with leukocytosis or fever. In many of the cases, they present really just with something that looks like VP shunt malfunction. They have increasing hydrocephalus. When you have increased hydrocephalus, their mental status always declines a little bit. And for these patients, that's always a thing you've got to look for. So you scan and you see increased ventricles. In some cases, you just have a malfunctioning shunt. That's all it is. It's something clogged up the tube or the valve. But about half the time, it's actually an infection that's causing all that. It'll plug up the tube just as well. In some cases, if you look along the subcutaneous tract, and it usually tracks down over the collarbone. They always install it on the right side. Tracks over the collarbone, and you can usually feel it going on down the subcutaneous tissues of the thorax and abdomen. And occasionally, I've seen too where there's actually this beautiful red streak going up along that track all the way up to the head. And that was kind of a big tip-off there. On a CT scan, occasionally you can see a rim of edema around the VP shunt. That's also a tip-off to infection at that point. The other place that you can get an infection here is actually down into the peritoneal area, where you basically coil up the end of the tube, and you can either get an infective or a non-infective peritonitis. Sometimes you just irritate the linings and you get some adhesions forming, and this results in loculated pockets of CSF fluid, or sometimes a frank abscess in the peritoneum. And yes, these tubes do sometimes actually enter into the liver or into the bowels, so you can get some polymicrobial abscesses. So to diagnose this VP shunt infection, probably the easiest way to assess this is to directly aspirate from the subcutaneous shunt. It's not that hard to do. Here we have, it depends a little bit on your neurosurgeon. And I'm sure Richard found out about this as well. There are some neurosurgery fellows who are happy to aspirate directly from the subcutaneous shunt. So you get all your cell counts, you get your protein, you get your glucose, and you get a culture from that. And it's really pretty convenient. And for all the patients I've seen aspirated this way, I don't think any of them have ever really been infected from the aspiration procedure, but it's a fairly small number, mind you. So I think this is a viable alternative, but you will find some neurosurgeons who don't want to do it, even because of the small risk involved. The findings sometimes can be very subtle, particularly with staph epidermidis. You may have relatively low white count, under 12 sometimes. The trick is that the neutrophils become increasingly predominant. That suggests infection. And what you really are dependent a lot on is that a positive culture is going to be the best indication of a shunt that's infected with staph epidermidis. If there are other organisms, they tend to grow not only in the CSF, but you often grow them in the blood as well. And the other tip-off here is with either MRI or CT is you see contrast in the ventricles or in the dura, suggesting that there's an inflammatory process at play. So same thing that we always do with all the other artificial material that's implanted is you remove the device. In the case of the shunt, you still need to maintain some sort of drainage. You just can't take the shunt out because they redevelop hydrocephalus fairly quickly. So what you do is you take the portion coming up out of the ventricle and you allow it to drain externally through secure connections and with a thought towards maintaining sterility. Now, this leads to an unusual situation in infectious disease where we have the opportunity to actually instill antibiotics straight into the CSF shunt and into the ventricles. And the use of intraventricular antibiotics is not really new. This was employed as probably even in the late 60s when gentamicin was found to be relatively safe for some types of ventriculitis or meningitis. Once you have sterile CSF, maybe up to like 3 cultures worth, you can replace the shunt at that point. And often that does the trick and the patient does okay. But you have to coordinate very carefully with neurosurgery in this, obviously. There are other types of shunts, ventricular atrial shunts. You really don't see those much anymore. The only thing there is that the other end of the shunt goes into the right-sided atrium, and there's always a risk of infective enterocolitis, usually with tip vegetations on the tube itself. And these are very chronic, and yes, this is one of the situations where you can get immunologic phenomenon and septic pulmonary emboli. In this case, it's because you actually have the infected tip in the bloodstream. In effect, in essence, is a type of endocarditis. Okay, so one thing we've noticed, and with some help from Richard Ailer here, with the numbers, the normal incidence of a VP shunt infection, and this is mostly based on kids with brain cancer or hydrocephalus, and their typical infection rate, I think this is like over 3 years or so, the incidence is normally like 3.5 to 9%. In the James A. Haley VMC Polytrauma Center, just going back to some of the studies that Richard had put together, the incidence is more in the order of about 20%. Talking to people at Walter Reed, they think that this is in fact true, that there's something about polytrauma, possibly due to shrapnel, possibly due to bone chips that have not been debrided out of the brain, that there's just a higher rate of ventricular peritoneal shunt infection in these patients. And we had one patient who's gone through, one patient went through 4 different VP shunts over a period of a couple years. Just pointing out that the presence of bone fragments and shrapnel is always increases the risk for subsequent infection in the head. Okay, I won't dwell on that again. Meropenem and vancomycin, if you don't know what you're treating and your cultures are negative, we'll go with that. But there is quite a variety of organisms that can cause infection, and nocardia is one that was actually seen here back a few years ago. It brought us some attention from Spectral General, but actually the patient was on meropenem appropriately for this. It was an uninspected bacteria. Okay, so the downside to intraventricular antibiotics is that not all antibiotics are useful in this setting. Gentamicin is approved for intraventricular use, and it seems to be very benign when used in that fashion. There are no controlled studies, probably never will be. However, you can't use beta-lactams inside the ventricle. It is toxic, and patients will seize if you do that. The positive side here is that there's plenty of data to suggest that the aminoglycosides in general, and gentamicin specifically, are non-toxic. And actually, vancomycin turns out to work very well inside the ventricle as well. And it seems to have minimal toxicity. And due to the fact that people at Walter Reed got desperate in treating their brain infections with Acinetobacter, we now know that Clistin also appears to be very non-toxic when used in ventricular fluid. So at least for meningitis, ventriculitis, or VP shunt infections, we have some surprisingly good drugs that we can use here, and without having to worry about renal toxicity or other forms of toxicity. There are a couple of different papers talking about dosing. If you actually just go to UpToDate online, and under their meningitis section, they have a whole section on the concentrations of antibiotic to use. The other thing would be the IDSA guidelines on meningitis care. When you go to the back of that, there's about 3 pages going over intraventricular use of antibiotics. Just point out that amphotericin B has also been used in this setting. It is slightly toxic. You can get some radiculitis with that, but you can see that there's a lot of drugs that you can use here. And finally, the Walter Reed protocol for Acinetobacter ventriculitis, which they seem to have had a lot of experience with, is you can use intravenous colistin, rifampin, and then you use intraventricular colistin at the same time every 3 days. Again, you coordinate with your neurosurgeon. Ideally, you just want to remove the entire shunt entirely once you've finished treating it, and you replace it with a totally new shunt is really the optimal way to do this. You get a response rate of 95%. If you try and preserve any bit of the shunt, you always have a much reduced response rate. And I'm not going to dwell on the duration. That's also, I think, in the IDSA document. Okay, so there are a lot of things happen with brain trauma, and beyond the infectious disease issues, I just want to speak to some of the other interests of the polytrauma group in terms of how to manage traumatic brain injury. Obviously, the focus is on rehabilitation, but there are a lot of other things that pop up here that are just of interest to me, and I'm not here to give any answers, but there is this phenomenon, particularly in patients who have significant brain trauma. with encephalomalacia on the CT, you look, you can see whole chunks of brain have basically atrophied, and occasionally you can see bits of brain material kind of floating around the CSF. I mean, these patients have some remarkably distorted anatomy. These are patients that will be culture negative, but if you were to do an enhancement study of MRI or CT, they have marked uptake in their meninges, sometimes in a focal, sometimes in a diffuse fashion. If you look at the CSF, you have this persistently high CSF protein, and you also have a pleocytosis. And Dr. Ayler and I have both been working with one patient who possibly had a real bacterial meningitis, but then over the last month has had these persistent increases in protein and pleocytosis, which has gone from mostly neutrophilic to something that's a little more of a lymphocytic predominance. We had 3 other patients who had had cranioplasties or craniectomies, where they actually took out some of the brain, and months after that event, they had contrast enhancement of parts of their brain, and when we did CSF, they also had very high proteins. They had low glucose, but nothing ever grew, and it's all it's sort of this aseptic meningitis that is a post-surgical phenomenon. Surprisingly, there's very little written about this. The neurosurgeons will always say, oh yeah, it's post-surgical changes, but I can't find a definitive paper that really goes through and discusses what the range of findings are. And I suspect that may be in neurosurgery textbooks, and I just need to look at it a little bit more. But there is this phenomenon. You may run into it. Patients who have had significant brain trauma or surgery will have abnormal changes, even in the absence of a positive culture. Well, I think so. I think it's in that same... there's this huge cranioplasty study they're doing, and it has some 500 patients or so, and I think there might be data in there. I don't know if I'm going to have any access to it. There's a lot of people who want to put their finger into that pie, but we'll see what comes out of it. Okay, now there's some other things too. The problem with brain trauma is it affects your consciousness, and we had this whole emerging consciousness program, and there's a real scope where you've got some individuals who wake up over a period of a couple weeks, rehab and do well. Others who, once they get their cranioplasty, you optimize the CNS hydrodynamics somehow. VP Shunt's important too. And you'll see them wake up. You optimize anti-seizure meds. Some of these patients seem to have almost continuous low-grade seizures, and Keppra or something, they'll suddenly pop up. And then there's some really strange stuff that happens up there in terms of drugs to increase alertness. Some of them are obvious, like amphetamines or modafinil, which is sort of amphetamine-like, but it works with a completely different mechanism. Amantadine, where we take essentially an anti-influenza drug and we use its major side effect in a therapeutic fashion in these patients. And then there's this thing where they use Ambien, what is it, Solabim? I can't remember well. Ambien, and which is normally a sedative. And in this case, in these patients, it seems to have a sort of a paradoxic property of increasing alertness. And there have been studies using functional MRI and SPECT scans where you can actually see increased blood flow to the cortex. So there's some very strange things that happen there. I mean, it's just, I don't know if it's a science at all, but you're kind of out on the edge there. So because of the heterogeneity of these patients, there's a lot of interest in somehow of identifying patients with traumatic brain injury to try in some way to quantitate the degree of injury, which isn't always easy to do by CT or MRI, because there are parts of the brain that may or may not, it'd be nice to have some sort of just marker that would tell you how much brain mass is damaged. And so now there's a lot of interest in biomarkers for traumatic brain injury. And when I say there's interest in that, these are tests that they're ready to start running downstairs in the main pathology laboratories. I'm kind of stumbling there because it's actually a research project and it's occurring on clinical space, and there's some issues about whether they have to designate part of their laboratory as research space, but I'm not going to go there. So there's 3 things you look at. One is called S100 beta. What this is, it's a protein that binds calcium. It's important for function of astroglia, and it's really a unique marker for astroglia. So if you think about it, if you're going to have brain trauma, you're going to destroy a lot of astroglia. And so this stuff's going to get released into the CSF, although actually you can measure it in the blood pretty well, pretty much as well, probably because of disruption in the blood-brain barrier. It seems to correlate very nicely with the extent of brain damage. It has prognostic value. If it goes sky high, suggesting more brain tissue damage, those patients seem to do less well, though there's still more prospective studies that have to be done. It peaks within the first 3 days and decreases out to about 2 weeks. Myelin basic protein is also another brain-specific marker because, of course, it is the major protein inside the myelin itself. It's also the target for multiple sclerosis in some cases. So it's obviously an important protein and increases in CSF and blood as well. And then there's one other enzyme, a non-specific enolase, which tends not to correlate with the amount of brain damage, but tends to be a good marker for neuroinflammation. These patients, once they've had brain damage, do seem to have an inflammatory response, which I think is the same thing as that post-neurosurgical aseptic meningitis, which is why I'm interested in this now, because I think these things, this is probably a continuum of immunologic damage that occurs within the brain after surgery or after traumatic brain injury. And in this case, in children, they were using this to try and identify kids who were particularly high risk from their brain injury. And this is CSF data. The blood data is a little more compressed. But here you're looking at nonspecific enolase in patients who had severe traumatic brain injury. And in the control CSF, I mean, it's essentially close to undetectable. And here you had this incredible spread, which is, by the way, that's not even a normal curve. You know, it's sort of interesting how it's almost like a continuous gradient there. But you can imagine that you can have cutoffs, and you can actually work this sort of data. And here's another group looking at the S100 beta. And again, same thing. You had this fairly extended spectrum of values with essentially zilch for the control. So this is a great system for A, determining whether somebody's had brain trauma, and B, how traumatic is that. I think the lawyers are going to be more interested in this because there's some discussion about people getting in a fist fight, and if the stuff goes up, then they can start suing people because there was brain trauma. Alcohol. I don't know. But then it really gets interesting here, and then University of Florida kind of grabbed onto this, and their bioengineering department recently has gone from using ELISA plate readers, and the data you saw there was all done using ELISA. It's very straightforward stuff. And you stick a little plate in here, it goes in, it reads it, and then you have statistical software. But it's lacking a little bit in sensitivity, and so what they did is in their dual sandwich ELISA, the detector part of the antibody combination, instead of just having a little horseradish peroxidase here as your readout, they have a fluor here, and then they attach it to a microbead that's intensely fluorescent. So if it binds to the antibody, indicating that your antigen of interest is there, it provides a much stronger signal. And what they've done is they've taken some of these insulin reading devices that diabetics use, and adapted them so then you have this little portable monitor where you can take a little bit of plasma or blood from a patient, and then you can run this assay on it. And the idea is that in a field situation, you can actually get a very rapid readout on the degree of brain trauma that's occurred, although it still takes a few days to peak, so I don't know if it needs to be that rapidly deployed. But this kind of goes into a theme here, particularly with the military, of beginning to miniaturize diagnostic devices for field use. Okay, along the emerging consciousness theme here, there's a lot of interest in functional brain imaging, and little lasers going out. We have SPECT here, which is really just a way of looking at blood flow and cerebral metabolic activity, so that you can see what part of the brain is working, what part isn't. There are PET scans where you use fluorodeoxyglucose. It essentially does the same sort of thing with less resolution. And diffusion tensor imaging, which is sort of the the new kid on the block. And it's very weird. This is kind of a perfect picture of what it's supposed to look like. And what you're looking at is, it's an MRI now, so that you can basically, you can look at the dipoles of water molecules as they're bouncing around. And when they're in a cortical spinal tract, and these are the cortical spinal tracts that connect all the different parts of the brain together in 3 dimensions. You can follow those water molecules, and they're constrained to the pathway because they're in between myelin sheaths, and they really can't go off to the side. So they're run up and down the cortical spinal path, and that allows a person with a really supercomputer to actually plot out these cortical spinal tracts. And in this case here, you have what looks like this is a normal brain with its spinal cortical tract. And here's a patient who has a genetic metabolic abnormality that results in loss of brain tissue. And you can see you actually drop out all these paths, and some of them seem not to really end up in anything. And the way they do this, a more practical way of handling this, is that when it's essentially it's an MRI, and what you can do is either before or after the scan, you can pick these windows, the green lines here, the yellow dots, and these are all areas where we know there's cortical spinal paths, and then they monitor activity here. It's either going up or it's going down, and you generate these bar graphs telling you whether or not there's a lot of activity. If there's a lot of activity of water molecules going up and down, then the pathway's intact. If there isn't, it's a dead pathway. Something's happened. Usually it's been disrupted by brain damage. And so they can actually get it's a little hard to show the outcome from it because it's bar graphs, and it's they haven't really optimized a great way to look at it. But what they can do, and this is from the Cambridge group in the UK, which has really turned this into an art form. Here they show that. So you can look at functional areas of the brain during a task, and what the cortical spinal tract studies with the DTI does is it really tells you what's connecting these 2 areas. And for speech, it's very important to connect several areas together through cortical spinal tracts, and they can sometimes identify types of aphasia that relate to the fact that the cortical spinal tract is damaged, and not necessarily the speech centers themselves. So that's kind of a whole new world in understanding brain trauma. And if you're going to do therapy for brain trauma, either pharmacologic or other types, maybe if you see improvements through these scans, then you're better able to defend your practice. Okay, and this is just one last thing. This is all along the lines of technological improvements. The Department of Defense has put a lot of money into systems, initially just for identifying microbial threats, say in a terrorist attack. And there's this company in Idaho Device Systems, that has made this thing they call JBAIDs, of which the DoD is buying a lot of right now, and they're beginning to deploy them into the field. And it's a joint biological agent identification and diagnostic system. It's a 40-pound device. This is essentially a real-time PCR machine here that's been miniaturized. That's based on a light cycler. They have a little core you put in there with these little capillary tubes. You got your reagents, and you have a computer that you hook up to it, and it does all the analysis for you. Fits into a rucksack, and operates within 40 minutes, and you have about 85 to 90% accuracy. There is essentially a universe of PCR primers you can get for about any organism you want, including PCR primers that will identify antibiotic resistance. The first generation here, they're only interested in identifying anthrax, BL3 sort of organisms. But they're also beginning to apply this to wound infection diagnosis, with the idea of getting a rapid output in terms of whether it's Pseudomonas, MRSA, MSSA, or Acinetobacter that's causing infection in the wound. And they're trying to get together panels of primers that will identify antibiotic resistance. So this is something that they're not only doing, but they want to take it into the field, and you'll have trained people in the field who will do this before they even get to the hospital. We'll see how it works. It's certainly very ambitious, and I was part of a conference where they were talking about this, and they really want to deploy this as rapidly as they can. And there's this continuum of funding, and they call it started at 6.1 all the way to like 6.10, each of which represents either very basic research, advanced research, and the very end part of that is something that actually gets into the field, and the only thing left to do is to train people to use it and start collecting data. So that's where they are with this right now. Okay, I'm going to stop off there. That last little bit is just kind of a teaser. The stuff that you can put together now.